Listen carefully. If you cannot clearly differentiate between DKA and HHS, you are walking into a guaranteed NCLEX trap. These are not basic textbook questions. These are the kind of clinical scenarios that make strong candidates second-guess themselves. Today on MCQs Master 101, we are breaking down 50 brutal DKA and HHS NCLEX questions using real clinical reasoning, lab interpretation, electrolyte prioritization, and treatment sequencing. If you want to think like a safe nurse, if you want to dominate insulin, potassium, anion gap, and fluid management questions, stay locked in. Let's treat this. Question 1. A 24-year-old client with type 1 diabetes presents with polyuria, abdominal pain, and deep rapid respirations. ABG results show pH 7.18, PaCO2 28 mm mercury, HCO3 12 milliequivalents per liter. Which finding should the nurse anticipate? A. Serum glucose 140 milligrams per deciliter. B. Serum potassium 6.2 milliequivalents per liter. C. Serum sodium 150 milliequivalents per liter. D. Absence of serum ketones. Answer: B. Serum potassium 6.2 milliequivalents per liter. Rationale: the client is in diabetic ketoacidosis, DKA. Acidosis causes potassium to shift from intracellular to extracellular space, leading to initial hyperkalemia, even though total body potassium is depleted. Glucose is typically greater than 250 milligrams per deciliter, and ketones are present. Question 2. A client with type 2 diabetes is admitted with glucose 980 milligrams per deciliter, serum osmolality 340 milliosmoles per kilogram, and no ketones. Which assessment finding is most expected? A. Q-small respirations. B. Fruity breath odor. C. Profound neurological deficits. D. Severe abdominal pain. Answer: C. Profound neurological deficits. Rationale: this client has hyperosmolar hyperglycemic state, HHS. Extreme hyperosmolality causes severe dehydration and altered mental status. Q-small respirations and fruity breath are classic for DKA. Question 3. A nurse begins insulin infusion for DKA. Which parameter requires the most immediate monitoring? A. Serum magnesium. B. Serum potassium. C. Hemoglobin A1C. D. White blood cell count. Answer: B. Serum potassium. Rationale: insulin drives potassium back into cells, which can rapidly cause life-threatening hypokalemia. Potassium must be greater than 3.3 milliequivalents per liter before insulin is initiated. Question 4. A client in DKA has potassium level 2.9 milliequivalents per liter. What is the priority action? A. Initiate insulin drip. B. Administer sodium bicarbonate. C. Replace potassium before insulin. D. Restrict fluids. Answer: C. Replace potassium before insulin. Rationale: insulin administration will worsen hypokalemia and may cause cardiac arrest. Potassium must be corrected first if less than 3.3 milliequivalents per liter. Question 5. A client in DKA receives IV fluids. Which fluid is appropriate initially? A. 0.45% NS. B. D5W. C. 0.9% NS. D. Lactated ringers. Answer: C. 0.9% NS. Rationale: initial management focuses on restoring intravascular volume. Isotonic saline 0.9% NS is the first-line fluid in DKA and HHS. Question 6. Which laboratory trend indicates resolution of DKA? A. Glucose less than 250 milligrams per deciliter only. B. Serum ketones present. C. Bicarbonate greater than 18 milliequivalents per liter. D. Potassium 5.5 milliequivalents per liter. Answer: C. Bicarbonate greater than 18 milliequivalents per liter. Rationale: resolution of DKA is indicated by normalization of metabolic acidosis, pH greater than 7.3, bicarbonate greater than 18 milliequivalents per liter, and closed anion gap. Glucose normalization alone does not indicate resolution. Question 7. A client with HHS becomes increasingly lethargic. Which complication is the nurse most concerned about? A. Cerebral edema. B. Hypoglycemia. C. Diabetic neuropathy. D. Pancreatitis. Answer: A. Cerebral edema. Rationale: rapid correction of hyperglycemia and hyperosmolality can lead to cerebral edema, particularly in severe cases. Neurologic changes require urgent evaluation.
Question 8. Which clinical finding differentiates DKA from HHS? A. Severe dehydration. B. Blood glucose greater than 600 milligrams per deciliter. C. Positive serum ketones. D. Altered mental status. Answer: C. Positive serum ketones. Rationale: DKA is characterized by ketone production and metabolic acidosis. HHS has minimal or absent ketones. Question 9. A client with DKA has blood glucose 220 milligrams per deciliter during insulin infusion. What is the next intervention? A. Stop insulin infusion. B. Add dextrose to IV fluids. C. Increase insulin rate. D. Administer glucagon. Answer: B. Add dextrose to IV fluids. Rationale: when glucose reaches 200 to 250 milligrams per deciliter in DKA, dextrose is added to prevent hypoglycemia while insulin continues to clear ketones.
Question 10. Which ECG change suggests worsening hypokalemia during DKA treatment? A. Peaked T waves. B. Wide QRS. C. U waves. D. ST elevation. Answer: C. U waves. Rationale: U waves indicate hypokalemia. Insulin therapy shifts potassium intracellularly, increasing risk. Question 11. A client with DKA has an anion gap of 28. Which finding confirms improvement? A. Glucose 180 milligrams per deciliter. B. Anion gap 14. C. Potassium 5.0 milliequivalents per liter. D. Urine output 40 milliliters per hour. Answer: B. Anion gap 14. Rationale: DKA resolution requires closure of the anion gap. Normal gap, approximately 8 to 16, indicates ketone clearance. Glucose normalization alone is insufficient. Question 13. A client with HHS is receiving IV insulin. Glucose drops from 900 to 760 milligrams per deciliter in 1 hour. What is the priority action? A. Continue current rate. B. Increase insulin rate. C. Decrease insulin rate. D. Stop infusion. Answer: C. Decrease insulin rate. Rationale: glucose should decrease 50 to 75 milligrams per deciliter per hour. Faster correction increases risk of cerebral edema. Question 14. A DKA client has Kussmaul respirations. What is the physiologic purpose? A. Reduce oxygen demand. B. Compensate for metabolic acidosis. C. Correct hyperkalemia. D. Improve glucose clearance. Answer: B. Compensate for metabolic acidosis. Rationale: Deep, rapid respirations eliminate CO2 to raise pH in metabolic acidosis. Question 15. Which assessment finding suggests fluid resuscitation in DKA is effective? A. Decreased heart rate. B. Increased glucose. C. New crackles in the lungs. D. Bounding pulses. Answer. A. Decreased heart rate. Rationale. Tachycardia results from hypovolemia. Improved volume reduces compensatory tachycardia. Question 15. A DKA client's potassium drops from 5.5 to 3.4 milliequivalents per liter. What is the priority? A. Stop insulin. B. Administer potassium. C. Restrict fluids. D. Give bicarbonate. Answer. B. Administer potassium. Rationale. Insulin drives potassium intracellularly. Hypokalemia increases risk for dysrhythmias. Question 16. Which client is at highest risk for HHS? A. 18-year-old with type 1 DM. B. 70-year-old with infection and type 2 DM. C. Pregnant client with gestational DM. D. Athlete with dehydration. Answer. B. 70-year-old with infection and type 2 DM. HHS commonly occurs in older adults with type 2 DM and precipitating illness. Question 17. Which lab value is most consistent with DKA? A. pH 7.40. B. HCO3- 24. C. Serum glucose 300. D. Serum osmolality 290. Answer. C. Serum glucose 300. Rationale. DKA glucose typically greater than 250 milligrams per deciliter. Normal pH and bicarbonate exclude DKA. Question 18. A client in HHS has sodium 158 milliequivalents per liter. What is the interpretation? A. Dilutional hyponatremia. B. Severe dehydration. C. Insulin excess. D. Renal failure. Answer. B. Severe dehydration. Hypernatremia reflects profound water loss in HHS. Question 19. Which medication error would most likely precipitate DKA? A. Doubling insulin dose. B. Skipping insulin for 2 days. C. Taking metformin. D. Eating high-protein diet. Answer. B. Skipping insulin for 2 days. Insulin omission is the most common precipitating factor for DKA. Question 20. Which assessment finding requires immediate intervention during DKA treatment? A. Glucose 250 milligrams per deciliter. B. Potassium 3.0 milliequivalents per liter. C. Urine output 50 milliliters per hour. D. Sodium 135 milliequivalents per liter. Answer. B. Potassium 3.0 milliequivalents per liter. Rationale. Hypokalemia during insulin therapy can cause fatal arrhythmias. Question 21. A client with DKA develops headache and decreased LOC during treatment. Priority. A. Increase insulin. B. Suspect cerebral edema. C. Administer glucagon. D. Restrict fluids. Answer. B. Suspect cerebral edema. Rationale. Rapid osmotic shifts may cause cerebral edema. Question 22. Which ABG reflects DKA? A. pH 7.48, HCO3- 28. B. pH 7.30, HCO3- 15. C. pH 7.50, PaC CO2 30, D. pH 7.40, HCO3- 24. Answer: B. pH 7.30, HCO3- 15. Rationale: metabolic acidosis with low bicarbonate defines DKA. Question 23. When should dextrose be added to IV fluids in HHS? A. Glucose less than 600. B. Glucose less than 500. C. Glucose less than 300. D. Glucose less than 250. Answer: C. Glucose less than 300. Rationale: in HHS, dextrose is added when glucose approaches 250 to 300 milligrams per deciliter to prevent hypoglycemia. Question 24. Which finding distinguishes HHS from DKA? A. Severe hyperglycemia. B. Metabolic acidosis. C. Polyuria. D. Dehydration. Answer: B. Metabolic acidosis. Rationale: metabolic acidosis is present in DKA, absent or mild in HHS. Question 25. Which electrolyte imbalance is expected in untreated DKA? A. Hypokalemia. B. Hyperkalemia. C. Hypocalcemia. D. Hypermagnesemia. Answer: B. Hyperkalemia. Rationale: acidosis causes potassium shift extracellularly. Question 26. Priority in initial DKA management. A. Insulin. B. Fluid replacement. C. Bicarbonate. D. Potassium restriction. Answer: B. Fluid replacement. Rationale: volume restoration is first to stabilize perfusion. Question 27. Which symptom is classic for DKA but not HHS? A. Confusion. B. Fruity breath. C. Polyuria. D. Dry skin. Answer: B. Fruity breath. Rationale: acetone breath indicates ketosis. Question 28. Which complication is most fatal in HHS? A. Arrhythmia. B. Severe dehydration. C. Metabolic acidosis. D. Hypoglycemia. Answer: B. Severe dehydration. Rationale: profound fluid deficit leads to shock and mortality. Question 29. Insulin infusion is titrated to achieve what glucose drop per hour? A. 10 to 20 milligrams per deciliter. B. 25 to 40 milligrams per deciliter. C. 50 to 75 milligrams per deciliter. D. 100 to 150 milligrams per deciliter. Answer: C. 50 to 75 milligrams per deciliter. Rationale: prevents rapid osmotic shifts and cerebral edema. Question 30. Which condition most commonly precipitates HHS? A. Starvation. B. Infection. C. Exercise. D. Hypothyroidism. Answer: B. Infection. Rationale: stress hormones increase glucose production. Question 31. DKA is characterized by deficiency of A. Glucagon. B. Insulin. C. Cortisol. D. ADH. Answer: B. Insulin. Rationale: absolute insulin deficiency causes lipolysis and ketone production. Question 32. Which lab indicates improving hydration in HHS? A. Rising hematocrit. B. Decreasing serum osmolality. C. Rising sodium. D. Increased glucose. Answer: B. Decreasing serum osmolality. Rationale: Correction of hyperosmolarity indicates fluid restoration. Question 33. Why is bicarbonate rarely given in DKA? A. Causes hypoglycemia. B. Worsens acidosis. C. Risk of cerebral edema. D. Increases potassium. Answer. C. Risk of cerebral edema. Rationale. Bicarbonate may cause paradoxical CNS acidosis and edema, reserved for severe pH below 6.9. Question 34. Which finding suggests worsening acidosis? A. Shallow respirations. B. Bradycardia. C. Increasing anion gap. D. Decreasing glucose. Answer. C. Increasing anion gap. Rationale. Rising gap indicates ongoing ketone accumulation. Question 35. Which population most commonly develops DKA? A. Type 1 DM. B. Type 2 DM. C. Prediabetes. D. Gestational diabetes. Answer. A. Type 1 DM. Rationale. Absolute insulin deficiency predisposes to ketosis. Question 36. Which assessment indicates fluid overload during treatment? A. Crackles. B. Tachycardia. C. Dry mucous membranes. D. Hypotension. Answer. A. Crackles. Rationale. Aggressive fluids may cause pulmonary edema. Question 37. Which lab trend signals effective insulin therapy in DKA? A. Rising ketones. B. Decreasing anion gap. C. Rising potassium. D. Rising glucose. Answer. B. Decreasing anion gap. Rationale. Reduction of keto acids. Question 38. Which is the earliest sign of DKA? A. Kussmaul respirations. B. Fruity breath. C. Polyuria. D. Coma. Answer. C. Polyuria. Rationale. Osmotic diuresis occurs early due to hyperglycemia. Question 39. Which hormone excess contributes to HHS hyperglycemia? A. Insulin. B. ADH. C. Cortisol. D. Oxytocin. Answer. C. Cortisol. Rationale. Stress hormones increase gluconeogenesis. Question 40. Which complication is more common in pediatric DKA? A. Shock. B. Cerebral edema. C. MI. D. Stroke. Answer. B. Cerebral edema. Rationale. Children are at higher risk during rapid correction. Question 41. Which lab confirms hyperosmolar state? A. Osmolality greater than 320 milliosmol per kilogram. B. Sodium 135. C. Glucose 250. D. Ketones positive. Answer. A. Osmolality greater than 320 milliosmol per kilogram. Rationale. HHS defined by marked hyperosmolarity. Question 42. A DKA client's pH improves from 7.12 to 7.32. What does this indicate? A. Worsening acidosis. B. Improving metabolic status. C. Respiratory failure. D. Hypoglycemia. Answer. B. Improving metabolic status. Rationale. Rising pH indicates correction of acidosis. Question 43. Which vital sign is expected in severe HHS? A. Hypertension. B. Hypotension. C. Bradycardia. D. Normal BP. Answer. B. Hypotension. Rationale. Severe dehydration decreases circulating volume. Question 44. Which assessment finding indicates DKA resolution? A. Glucose 180, B. Closed anion gap, C. Potassium 5.5, D. Sodium 150. Answer B. Closed anion gap. Rationale: anion gap normalization confirms ketoacidosis resolved. Question 45. Which client education prevents DKA? A. Stop insulin when ill. B. Increase insulin during infection. C. Skip meals. D. Restrict fluids. Answer B. Increase insulin during infection. Rationale: sick day rules require continuing or increasing insulin. Question 46. Which lab abnormality is most dangerous during treatment? A. Hypoglycemia, B. Hypokalemia, C. Mild hypernatremia, D. Low chloride. Answer B. Hypokalemia. Rationale: can cause fatal cardiac arrhythmias. Which symptom is more severe in HHS than DKA? A. Ketosis, B. Acidosis, C. Neurological impairment, D. Abdominal pain. Answer C. Neurological impairment. Extreme hyperosmolarity severely affects CNS. Question 48. Which fluid is appropriate after initial resuscitation if sodium is high? A. 0.9% NS, B. 0.45% NS, C. D5W, D. LR. Answer B. 0.45% NS. Hypotonic solution corrects hypernatremia gradually. Question 49. Which is the primary cause of acidosis in DKA? A. Lactic acid, B. Respiratory failure, C. Ketone accumulation, D. Renal failure. Answer C. Ketone accumulation. Fat breakdown produces ketoacids. Question 50. Which assessment finding confirms both DKA and HHS are improving? A. Glucose normal, B. Urine output adequate, C. Stable vital signs, D. Improved mental status. Answer D. Improved mental status.
Rationale: neurological recovery indicates improved perfusion and osmolar balance. If you made it through all 50 questions, you're not just studying, you're training at exam level. Remember, NCLEX doesn't test memorization. It tests prioritization. It tests safety. It tests clinical judgment. And DKA and HSS are classic fail zones for unprepared candidates. If this video stretched your thinking, hit the like button. If you want more high-level, exam-destroying questions, subscribe to MCQs Master 101. Drop in the comments, how many did you get correct, honestly? Next video, we go even harder. Until then, stay sharp, stay clinical, and pass that NCLEX.